So we are joined today by Dr. Kara Hope, Megan Knutson-Sinais, Nellie Koinones, and Ayana Williams. Thank you all for joining us today. My name is Maggie Snyder, and as many of you know from the last session, I'm a lead public health advisor in the Office on Women's Health here at HHS. I've been having some technical difficulties today, so at some point in the session, if I need to, I may go off of video, but we will continue regardless. Great, so we're going to start with a fairly general question for all of our panelists. For a brief summary of each of your programs. And we'll start with can
you say the name again? You cut out right as you were about to say who you wanted to start.
Excuse me. We'll start with Dr. Hope.
Okay.
It looks like you're muted, Dr. Hope.
Would be helpful if I turn that on, huh? Can you hear me? Yes?
Yes.
Well, it's a pleasure to be here today. I was here last year and so excited to come back again. And I think this session is such a great topic. Megan Knutson-Sinais is with me today. She's a member of our program and helps lead the health coaching and behavior change intervention that we're currently working on. So you'll hear from her a little bit. Our program started some time ago, back in about 2016-17, and it really started with postpartum remote patient monitoring. And over time with, different research studies and community input, we've titled our program Staying Healthy After Childbirth, or STAC. We do have a website, and we do have a non-research based full intervention that all pregnant postpartum patients go home with remote patient monitoring. So we serve around 1,500 patients a year, and we have a full nurse monitoring team. And, just reflecting on some of the comments before, comments about providers or nurses not having time to react promptly or provide the care that people need. I really am very proud of our nurse-centered program because they're available every single day and are there to immediately serve the blood pressures and act on them and treat them and manage them and really guide patients through those critical 6 weeks postpartum. We had found in the past some health inequities, and so we, through different phases of this mechanism, have worked with community partners specifically to improve outcomes for our Black birthing patients, and working with community-based doulas with a specific interest in improving Black birthing outcomes. So we've piloted that and found very strong benefits of that doula partnership in our program. And so each patient would be in our program with a community-based doula, which allowed for improved blood pressures, breastfeeding, and social support. And then our more recent adventure is about postpartum, that gap from 6 weeks to 12 months. And that's what Megan is helping lead. So we have a randomized control trial, and it's a 12-month health coaching intervention with motivational interviewing. And one of the key parts, again, being able to loop back in with their primary about lack of blood pressure control or need to, adjust meds and other things. And it's very exciting. And we've also done other work in non-pregnant adults with health coaching too. So really excited to hear what everyone has to say. And that's just sort of a blurb about what we do. And also I'm in Wisconsin, University of Wisconsin-Madison.
And we'll move on to Megan. If there's anything you'd like to add to that.
Dr. Hoppy gave a nice overview, and I'll maybe talk more when we get further along to our other questions addressing kind of how we deliver this intervention. Thank you for being here today.
Excellent. Great. So let's move on to Nellie Koinones, brief summary of your program.
Sure. Hi, I'm Nellie Koinones, and I'm one of the managers of nursing practice with the National Service Office for the Nurse Family Partnership and Child First. And the Nurse Family Partnership is an evidence-based home visiting program that pairs a registered nurse with low-income clients, beginning early in pregnancy with a first child, and then provides ongoing home visits through the child's second birthday. through client-centered visits, the NFP nurse partners with the first-time mother and birthing individuals to address the emotional, social, but also those physical challenges that they may face in preparing for a healthy birth, right, and for parenting. The long-term pairing of the nurse also provides clients with resources and knowledge to navigate the sometimes difficult path to lasting financial autonomy as well. Our program currently serves first-time low-income mothers in 40 states in the U.S. Virgin Islands and several tribal communities. So the program works within the context of that relationship between the nurse home visitor and the client. Thank you.
Excellent. Thank you so much, Nellie. It's great. Succinct.
Meg, you cut out there, but I'm assuming that you're kicking it over to Ayana.
I'll make that assumption as well. Hello, everyone. My name is Ayana Williams. I'm a public health analyst at the Health Resources and Services Administration. And HRSA, for short, provides equitable healthcare to the nation's highest need communities. And our programs support people with low income, people with HIV, pregnant people, children, parents, rural communities, transplant patients, and the health workforce in those communities. So as part of HRSA's response to COVID-19, the federal response, the U.S. Department of Health and Human Services implemented the National Hypertension Control Initiative in 2021. And this was a partnership between HRSA as well as the Office of Minority Health. And it seeks to improve COVID-19 related health outcomes by addressing hypertension control, so improving high blood pressure, specifically among racial and ethnic minorities. So as a part of the National Hypertension Control Initiative, HRSA funded or awarded nearly $90 million in supplemental funding to 496 health centers. And that funding was meant to conduct outreach and engage patients with uncontrolled hypertension, to support training and technical assistance activities for the clinical teams, as well as support teams that are providing resources to those hypertensive patients. And then it also was meant to ensure access to Bluetooth or wireless enabled self-measured blood pressure monitoring devices, otherwise known as blood pressure cuffs, which I know has been spoken about quite a bit on today's summit already. So these 496 health centers have participated in training and shared their data throughout the process, and we'll talk a little bit more about that later. But overall, the interdisciplinary nature of this work has meant that not only these nearly 500 health centers have been a part of this initiative in improving hypertension control through self-measured blood pressure monitoring, but it's also meant that other community stakeholders, community health workers, community organizations, churches, and others have been a part of this effort as well. So thank you so much for inviting us to speak on behalf of these many incredible health centers doing this work.
Excellent. Thank you so much, Ayana. It's great to hear such widespread work affecting so many different programs. That's wonderful. Great. So we'll move on to the second question. And we'll start again with Kara. How have you empowered your patient population to control their hypertension through positive behavior changes? And what lessons have you learned from this?
I'm going to share this one with my co-presenter, Megan. But I just, I want to say first and foremost is just meeting people where they're at, making sure that people are properly educated, and also the healthcare system and community. And I have a large respect for the impact of community partnerships in helping build that trust, but also help follow up and the continued follow-up needs and the importance of that. And I think the second part is giving people the tools to succeed. And so some of that is, we make sure everybody has a properly measured arm and a properly measured cuff, as well as a BP monitor, and building bridges, to help share that back with your provider. And then also tools, to advocate, this isn't right. I need help, or, because people are turned away quite often. And I think, Megan can share that a lot because she's in the trenches providing this care and even trying to advocate for patients, and she gets turned down sometimes. So I'll let her share a little bit of her experience, but those are some of my biggest pieces.
Sure. Thank you, Dr. Huppy. So for this study, our health coaching is conducted over the phone. And so they get a blood pressure monitor through STAC. So everybody has one of those. And then we have a control arm and our intervention arm. Our control arm is standard of care. So we're a bit hands off for the first year postpartum to compare outcomes. With our intervention group, I call every other week for 4 months and then once a month for 6 months. And we started this study in February of this past year. And so it's ongoing. And I think the regular checking in, and we ask that they measure their blood pressure at least a couple times a week, daily if possible, but it doesn't need to be daily because that can be a barrier for a lot of these mothers. And so just to have regular blood pressure measurements to share with me over the phone so that we can assess, are they under control? Are they hypertensive? And if not, then we reach out to their primary care physicians for them. And as Dr. Hobby mentioned, sometimes primary care physicians, even though they're hypertensive, will say, oh, that's not too bad, and brush it off. But that's our protocol, that we at least notify them so that they can engage with their patient to help get them to goal. And then on our phone calls, we focus on lifestyle behaviors that can help with blood pressure management that are evidence-based. We go off of American Heart Association's Life's Essential 8. So a lot of our discussions focus on nutrition, exercise, stress management, compliance with blood pressure medications, and it does vary person to person what they want to focus on, what they're interested in, and what their own unique barriers are. And using the motivational interviewing techniques, like Dr. Happy mentioned, meeting them where they are, seeing just what we can do to help each person with their own unique barriers. We do work with a social worker as needed. Some folks have housing concerns, affordable childcare concerns, transportation concerns. And so it's nice that through the clinic, we do have some resources to help, individual barriers to care. But with motivational interviewing, it's really trying to draw out from each patient their sources of motivation and their own reasons for change and highlighting those reasons. So not telling them what to do. Obviously, we know what the guidelines are for exercise, nutritional intakes, but really having them verbalize for themselves what their own goals are. And when they're open to it, providing that information sharing with them so that they can show the discrepancy of where they are and what the guidelines are and how to get them closer to that guideline level as well.
And just to say one more thing, I'll be quick, but this opportunity that we have from 6 weeks to 12 months to engage with people, I think is really impactful, because we often end prenatal care at 6 weeks, and then there's major gaps until somebody has another pregnancy or maybe hits menopause. And we have really high rates of compliance and participation in this particular population. And it's interesting to reflect, because we ran a different trial called My Heart, and it was the same intervention, but we had the calls through 6 months, and we did not have behavior maintenance from 6 months to 12 months. And so we did kind of a social media poll of postpartum patients to modify this intervention, and found that they actually wanted more than what they were given in the past trial, and they wanted this maintenance phase. And so we're hoping that this will help kind of instill those behavior changes in education that, can be more lifelong.
Excellent. And the whole woman herself. That is something that we strive and affecting women's lives across the lifespan at every stage of health. Great. So we'll move now to Nellie. Same question. How have you empowered your patient population to control their hypertension through positive behavior changes? What lessons have you learned from this?
Yeah, so we're a nurse home visiting program where we're not specifically focused on hypertension, although hypertension is one of those things that we do work with our clients on. The program is client-centered, right? Meaning that all that a nurse home visitor does with a client puts the client first. We recognize the client as an individual, and we respect who they are and where they're in their life journey. And so the role of the nurse home visitor is to partner with the client on that journey. The nurse brings the expertise on the clinical part, and the client brings the expertise on themselves, right, in their lives. So to empower a client on any topic area, including hypertension, they must have good information about the topic, right? So we encourage nurses to keep current with their own knowledge about hypertension so that they can provide education and guidance on the diagnosis, what are the modifiable lifestyle risk factors, and what can be done to mitigate these. The education that is offered to the clients is offered in the context of a conversation, right? Which starts off by recognizing the client's already existing knowledge about a particular topic and building on that. And through that, the nurse home visitors are able to inform, but also to begin to build self-efficacy by being able to affirm the client for having gained what knowledge they already do have. Once the client's informed and expresses understanding, the nurse home visitor can begin to have those conversations using motivational interviewing to elicit a client's own good reasons to change a behavior. After the client is able to share those reasons to want to change a particular behavior, the nurse can begin to support the client as they plan for their change by setting goals and thinking of the steps necessary, right, to get to that goal. The nurse home visitor through the ongoing visits will then be checking in, right? How's it going for you? How did you agree to, take a walk around the block twice a week this week, right? Or you agreed to have more water, or whatever the behavior change was for that particular time. We'll go in and check in and continue to check clients' motivation, not check it, but really determine if the client's still motivated for a particular goal. In terms of lessons learned, we're thinking of the importance of relationship, right? I think we knew that, and I think it keeps getting reinforced. This work can't be done if there's not a trusting relationship. In order for a nurse home visitor to fully support a client, the client needs to feel comfortable being vulnerable, sharing their needs, sharing their lack of knowledge, lack of resource. And so it's really important for that trusting relationship to be developed early on in the dynamic so that the nurse home visitor can truly support the client with any of those behavior change needs.
Thank you so much, Nellie. And we're hearing that. So that sounds like a common theme. Great. So same question, Ayana.
So engaging patients to participate in SMBP self-measured blood pressure monitoring. We know that patient engagement is it's a common barrier. So while some health centers are using outreach and phone calls and other ways to engage patients and seek to help them get more involved to measure their blood pressure consistently for that 2 times a day goal, some health centers are finding success with really addressing and providing, as has been mentioned before, patient education to patients while they're in clinic or while they're at the health center. So due to staffing shortages, one health center actually noted that they are holding enrollment events when multiple patients are invited. So almost having a centering educational activity where they can have multiple patients come with their devices, with their blood pressure cuffs to do awareness activities, to talk about the importance of following the protocol, of ensuring that they can teach back the method of how to utilize the blood pressure cuff, and also understand the importance of not sharing that cuff with other individuals, perhaps in their family or in their home, to ensure the quality of the data that's being submitted to the clinical team. Another health center has addressed some of the challenges by developing an onboarding toolkit that actually is dual purpose. One, it onboards and provides information about the blood pressure cuff, about the systems in which the data will get from the blood pressure cuff into their medical record at a high level, of course. But that same toolkit is also used to utilize for staff at the health center, so that when there are high turnover events that take place, as we know, health center staff have been challenged with many of the issues of just medical staff in general over the past few years, and high turnover is great, that there is consistency in how patients are educated about the use of these blood pressure cuffs. We've also found that higher patient engagement using teachback, as I mentioned before, and motivational interviewing has really helped increase participation in SMBP in these health centers. So scheduling frequent follow-up visits with these patients, or having virtual visits with these patients to ensure that they're still using their cuff, that they still understand the importance, and if they have any questions, bringing them into that patient-centered model of care to be able to ensure that they have all the answers they need.
Great. Thank you so much, Ayana. I hear that my audio is also cutting off, so I'm going to hand.
That was very aptly timed, Maggie, because as you said, you were
Yes.
handing it over to me, it cut off. So no worries. Happy to step in. So I want to pose the next question. I think that was everyone for that first question, if I'm not mistaken. So the next question that I want to pose to you all is related to barriers and challenges. So any unique barriers or challenges in hypertension care when you're focusing on this behavior change, and those maybe can be reframed also as unique opportunities. So we can go in reverse order. So we'll start with Ayana.
Thank you. So again, I just want to emphasize when we're dealing with a technology device, such as a blood pressure cuff, where it's not just reporting the blood pressure to that particular patient, but it's also submitting it or transmitting it to the care team, there are a lot of challenges that can be faced. And these are not to fault the patient, but it does require it is important to address these when thinking about behavior change. So one, education is very key, but also letting patients know that there are other barriers and factors involved in having a successful SMBP transmission. So letting them know that if there is a third-party app between the electronic health record and between the patient that is transmitting that data, helping bring them into that process, not overwhelming them with information, but letting them know that how to use the app, how often you should use it. Are there any educational resources that can be used? We find that pictorial tools, so not just those that have writing on them, but actually showcase the different screens that you would see when you're using your blood pressure device, as well as the screens you would see on your app as you're using the blood pressure device, that those have been very helpful in increasing awareness and understanding of those tools. Another thing is helping patients know that, again, not all of the barriers are under their control. So when using Bluetooth devices or Wi-Fi enabled devices, access to internet, access to cell phone service is incredibly important, and consistent access is that. We know that several patients, not just in rural areas, but are having challenges with access to these resources, which then makes it very difficult for them to transmit their data. So when health centers are having these touch points with their patient populations, it's important to recognize doing the best that you can. Are there any ways that they can be supported? So health centers are utilizing their caseworkers, their social workers, community health workers, promotoras to help them meet some of these challenges that may be impacting the transmission of data. So I'll stop there. Pass it on.
Yes, thank you so much, Ayana. Nellie, you are up. Same question. I popped in the chat. What are some unique barriers or challenges to hypertension care that focus on behavior change and some unique opportunities?
Yeah, so I think that all of the barriers and the challenges that the nurses encounter are unique, as every client and every client situation is unique, right? And this is why it's so important for the nurse home visitors to provide individualized care to each client. Two clients may be at the same gestational age, they may have the same diagnosis of hypertension, but all the underlying circumstances may be completely different. Perhaps you have a client who has a language barrier, and another client who might have a cognitive delay, or perhaps there might be access to other resources, right? And so I think every client encounter is a unique opportunity for the nurse home visitors. I think that was actually a shorter answer.
No, that's perfect and a really great point. Absolutely, of meeting people where they are with what folks need individually. Thank you. So then Kara and Megan. And Kara, you're muted.
Sorry, I keep doing that. The most immediate thing I think is really making sure patients understand why they need to engage and that they have hypertension, what it can do. Because if they don't understand the point, you can give them all the tools, but they don't participate. And so I think that's the most important. One of the most important things is to meet patients where they are, but have them understand, educate them, and then they're like, oh my God, yes, I want to do this because I want to have good health. Or another thing is like barriers for transportation and things. And so technology can be a win to help people access care and eliminate like transportation needs and other things. And so again, unique opportunities. again, but being cognizant about, barriers to like cell phone access or Wi-Fi or whatever. Our program is unique in that the hospital covers that fee for patients through those first 6 weeks. So those barriers can be eliminated. And then I just wanted to touch on one of the biggest things we found is that even though we put in referrals at 6 weeks postpartum from our program to try to bridge that gap to continued care, like less than 30% were actually going to care in that next, 12 months. And so hence health coaching and self-empowerment and things like that. So shout out to Preeclampsia Foundation. We do use their tool for, bridging those 12 months, getting labs and how to talk to your patient, things like that. And then I'll let Megan tell you a little bit more about some of the unique barriers and challenges she sees with patients and how she deals with them.
Sure. Much like Nellie shared, it varies by person to person. And so we use SMART goals. That just helps paint the picture for these patients. So you can imagine a lot of women lack free time to exercise or even time to go grocery shopping or cook a healthy meal, time to measure their blood pressure, remembering to take their medications, time to calm down, to manage their stress. These are things that we talk about a lot with these participants. And so SMART goals, so kind of asking open-ended questions of, okay, you want to exercise more. What would that look like for you? What days out of the week? What would you be doing? How long would you want to do that for? Oh, you don't like to run. So what do you like to do for exercise? And let's maybe focus on that, as there's no one right way to do it. Giving them grace and letting them know that something is better than nothing, and starting those habits, and then eventually, supporting the growth over time is good. And, there's some barriers, having resources, shopping for food. So there's a food share program. So discussing, okay, when you get this supplement, and then when can you go grocery shopping, those sorts of things. So really painting it out with each individual, and each individual phone call is helpful for meeting their goals. And we, for this study, have a cell phone, which has been helpful. We have a participant that likes me to text her to remind her to take her medications. So we're trying that, and we'll see when I check in with her next week if that has been helpful. So far, she has gotten back to me that she took her medications today. So that's lovely. So again, it's very much person by person, and then having them decide for themselves what will work, and then supporting that, as everybody has unique barriers.
Yeah, I really appreciate that. And I'm actually going to jump ahead to another question in our list, because it dovetails really well with that. Is, when you have individuals that have more barriers than some to positive behavior change, for example, like you all mentioned, limited access to transportation, living in food deserts, lack of access to space or physical activity. You sort of started to touch on that, Megan, but how do you all address that? And maybe you could speak to as well, not only with the individual themselves, but maybe some other organizations in your community, and having those conversations of how can we remove these barriers for the individuals in our communities. And Nellie, it's okay, I'll start with you.
Sure. So, we, like I said earlier, we think that the clients are the experts on their own lives and their own circumstances, and we believe that every team should be the expert on the communities that they serve, right? So the teams know what resources are available in the communities, often creating resource guides. And because they know what the resources are, then they also know where the gaps are, right? So they can then collaborate with other community partners, perhaps through a community advisory board, to learn of additional resources, but also to advocate for additional resources, right, to be brought into those particular communities. The nurses work with clients, as I mentioned, with an individualized approach to determine how best to support the client with the resources that they do have access to, right? So sometimes this might mean looking at creative ways to support the families. So in the example of, not having limited public space, right? Limited access to public space, perhaps the nurse can do walking visits with the client, or offer alternative activities that could be done within the home, right? At home. Perhaps the nurse and the client will look for community centers or churches, right? For that offer classes or other ways for the nurse to get those, for the client to get those activities. Perhaps the nurse will work with the client to find, well, is there an online, like a YouTube video that you like to watch, right? That you can, that you can do at home that you don't necessarily need to look outside for. So yeah, it's all about knowing what all the resources are, who all the community partners are, advocating for resources that aren't available in your local community, communicating with or having relationships with your local legislators, right, in order to be able to say, hey, this is missing, we need this, right, and then bringing those services into the community, and then working creatively with the clients, right, in order to support them. If there's a food pantry but it's too far away, then learning what the resources are for transportation, right? So really working creatively, I think is
Absolutely. That's the name of the game in a lot of these situations, is just thinking outside the box. Ayana, I will go to you for the same question.
Well, I'll echo what Nellie said about the importance of care coordination, but not just across health institutions, but also across the social services institutions as well. We found that of the almost 500 health centers in the NHCI, some of the highest risk, most difficult to reach populations are those who are unhoused, those who are migrant populations and refugee populations. So care coordination with organizations that are able to, that are in touch with any of those populations throughout the year, or throughout a time period, really help in helping them control their hypertension control and staying a part of the process, even in times when they may move. And then the second thing that we hear a lot from health centers are the importance of tailored educational materials, as well as tailored services to help them be a part of increasing their blood pressure. And oftentimes that means providing resources in a language that is not commonly available through translation services, as well as activities that are outside of the traditional outreach patterns. So I'll stop there.
Yeah, absolutely. I think the language consideration is such an important one, not only different languages, but then also when we look at reading level and using plain language as well. And then I'll kick it to Megan and Kara.
I think my only kind of comment is to echo what everybody else has said, but that sorry, I lost my train of thought for a second, was, that people can't accomplish their health goals if they have barriers. And a lot of people have social barriers. And so using social determinants of health tools or, screening, because even the most difficult of patients, early on, our nurse team would be like, I can't contact them. They won't answer their phone. Like, it's taking a lot of time. It's, if only people would engage. But again, if you educate them to engage and why they need to engage, people will. But it's often that people aren't trying to be difficult. It's that they have like need to find a place to sleep or food to feed their family or other things. And so I think this has been echoed throughout this whole afternoon, is just overcoming life barriers to get to the things that also need to improve their health. So Megan?
Yeah, I would agree. I think, I've shared with Dr. Hoppy, we have one participant that has a lot of life stressors, and we all probably know a lot of patients that are like this, but, to keep showing up for her, even if we don't have the most coherent conversations, I will still call her every other week for 4 months as our study protocol dictates. And she always, at the end of each call, says, thank you for calling me. I appreciate you checking in on me. And she wasn't really home monitoring a whole lot with her monitor. So I would just encourage and ask, do you need another monitor? Did yours break? Did it get lost? No. And she finally gave me her most recent measurements and they were at goal. So that's good. And so I think just not giving up on people, even when the case doesn't seem to be going anywhere, but just, being a support person for them. And that's the point of Dr. Hoppy's Stack My Heart Peace study, is a layer of support beyond 6 weeks postpartum. And we do get a lot of buy-in because women appreciate that. And then also want to help other women in the future that face similar health concerns and scares, such as high blood pressure in their pregnancies, and want to make it better for other women in the future. And so Yeah, that's one way we help. And I think to note, Dr. Hoppy did look into gym memberships for this study. We called our local YMCA and they were very supportive. It just wasn't, it was out of the budget for this study. So in the future, if it allows, we want to try to be able to offer that for research participants so that if there are barriers to exercise, we can offer at least an option of an indoor facility, because in Wisconsin, winter can be really hard for people that are lacking resources or space at home to exercise. So that would be something neat in the future with more funding that we potentially could provide. There might be other barriers to that, transportation and whatnot, but you know, it's a start.
Yeah, and one other thing that Megan and I talk about, and Megan's an exercise physiologist, and so she was sharing with me recently, there's health reimbursement models for cardiac recovery and rehab and atrial fibrillation and other medical conditions, but like not preventative, exercise programs for preeclampsia recovery and other things. And so we've actually reached out to some of our HMOs to be like, hey, like there's billing codes for this and other medical conditions. Like, could we talk about, advancing it for these patients too? So thinking about how we could really advocate, for billing reimbursement for cardiac health.
Mm-hmm.
Yeah, such an important point of being looking at a systems approach. I love this conversation because in a past life, I have been a certified health coach. So hearing all these buzzwords like motivational interviewing is just amazing. I love it. And so important, to take that strength-based approach of recognizing that people have the barriers that they have and they, meeting them where they are and validating those challenges. But then I think, like Nellie said, thinking creatively about how can we make this work. So I did want to dig a little bit deeper into that and ask specifically like tools or strategies that you've used with patients. And so if it makes sense to use like a patient example, but just, maybe a little bit beyond using things like motivational interviewing or appreciative inquiry, like some tools or strategies for folks on the call who maybe are facing some of the same barriers that you all are with patients. And Ayana, if you are comfortable with that, you can kick us off.
Yeah, so I'll actually defer to the other panelists on this call to be able to speak specifically to their patient level work.
Nellie?
So I mean, it's interesting because in this program, nurse home visiting program and the intervention is the nurse, right? It's the nurse who's going to be going into the home and supporting the family. And so our goal is to equip the nurse home visitors to be able to go into the homes and then support the families, while they're in there with hypertensive issues, with preeclampsia, with whatever is going on with the client. And so in terms of equipping our nurses, we've introduced like a cultural consciousness pathway, right, which is focused to support families to deliver the program through a culturally conscious lens. We certainly recognize that implicit bias, right, racism exists in the healthcare system, and that it's contributed to disparities in health outcomes for women and birthing individuals of color. And we know this has been longstanding. We know that this has been persistent, and so we want to make sure that nurse home visitors are practicing from a place where they know about it and how it impacts clients, how it impacts families. And so the pathway encourages the nurses to use the nursing process, right? Assessment, diagnosis, planning, implementation, and evaluation for care for families that are different racial backgrounds, ethnic backgrounds, but also the LGBTQ2S plus, right, clients, in this culturally responsive approach. We've introduced a reflective practice framework called Facilitated Attune Interactions that supports this flexible, reflective, and supportive interactions with families. It's a trauma-sensitive framework that supports people to feel connected and understood within the context of that relationship. And really what we want to do is we want to make sure that nurse home visitors are communicating in a way that allows the clients to maintain engagement, right? And which is really important because the client can't benefit from the resource of the nurse if they're not staying in the program, right, or keeping their visits. And then we have, really practical tools, just handouts, right, that we call facilitators that are intended to facilitate conversations around topics around, such as hypertension or preeclampsia, what it is, how to manage, when it becomes a danger sign, right? What is normal and what is not normal. We also encourage teams to use resources outside of our education and facilitators, such as handouts from the Preeclampsia Foundation, from the March of Dimes, from the CDC, from ACOG, from A1, because there's a lot of information available. Nurse home visitors, we incorporate blood pressure screenings during regular home visits, and this presents an opportunity for both monitoring and education, right? There are some teams that have been able to secure at-home blood pressure devices, and the clients are taught how to monitor their own blood pressures. And the nurse home visitors definitely contribute important information about the client's blood pressure in the home, as well as providing education and observing demonstration and on obtaining accurate blood pressures in the home setting. We also know that, about 40% of pregnant people who present with new onset hypertension or proteinuria during pregnancy will progress to having preeclampsia. And so any vague symptoms definitely should be explored and prompt further assessment. So the nurse home visitors also assist clients to develop a plan to communicate with their OB providers. Should they have consistently elevated blood pressure readings, or if they have any of those symptoms or their danger signs. When the client is open to it, we also encourage the client's families, partners, or support systems to join the home visits. So they can also learn about the hypertension and those danger signs. And if that's not feasible, we always leave the facilitators, right, that they can then share with their family members or their partners when they get back. We are also, as nurse home visitors, in a unique position to advocate for our families, but we also teach families to advocate for themselves. Right? We want to make sure that the nurse home visitor is talking to the client about, hey, if you are feeling XYZ thing and it's not normal, it's okay to be persistent. It's okay to, tell the doctor, I need you to check this out, right? I need this to be explored further. So it's really about, that part is really about empowering the client, again, with all of the knowledge, right, that they can, and then equip them with the tools to then go ahead and advocate for themselves.
Thank you, Nellie. And I love to see that as a theme of this patient empowerment and self-advocacy coming across on several panels today. So I appreciate that. Dr. Hopi.
I'm going to defer to Megan because she's the expert in this area on my team.
Thank you. So the tools, again, would be the home blood pressure monitoring. So Dr. Hopi makes sure that all of her patients go home with a blood pressure monitor. It's a new policy through the hospital that they get to keep those monitors. Our study started out where we were mailing the monitors. We don't ask for them back. They're theirs to keep, but now everybody in her STAC program gets one of these monitors. And so they have it. And so that feedback, so self-regulation theory, they get a blood pressure measurement. Are they at goal? Are they not? And then we follow up with primary care providers if not. And then we have successfully had providers reach out, titrate medications to get patients at goal again. And so I think just that close follow-up with the healthcare team is one of our tools for success with this study, that engagement with healthcare piece. And then they also receive a weight scale from us, as weight management is important for high blood pressure control. Not everybody, but a number of our participants have a goal of weight loss. And so the weight scale can help with just knowing where they're at, again, that feedback. And then the Preeclampsia Foundation form that Dr. Hopi mentioned, everybody receives that when they leave the hospital. We send them another form with our study packet when they enroll for our intervention. And so on our first call together, we explain why we're providing this intervention, why we want to use this form as a tool for them to kind of track health outcomes in their first year postpartum, to track their blood pressures, to track their weight, to have some preventive lab work completed within that first year postpartum. Just knowing and providing that information to them that they are at increased risk for developing cardiovascular disease later in life, but there are significant things that they can do to reduce their risk. I always let them know, like, I don't mean to be doom and gloom. It doesn't mean you will get it. We just know through the science that your risk is increased. So let's address it now so that we can prevent that down the road. And so by checking your cholesterol, so if it's out of a healthy range, you can do something about it, or your blood sugars, you can do something about it. So those are, tools that we use. And then the regular checking in with folks and being that reminder, because when you get a form, when you have a baby, and then a year later to remember to use that form, hopefully we find through our study by receiving health coaching through that first year postpartum, maybe they will actually use it more in follow up. And we do have a number of participants that have scheduled their lab work already. So that's good to hear and see. So I think there was something that came through in the chat. Maybe I'll just look real quick, because as a physical trainer, that might be geared toward me as an exercise physiologist. So we do, UW does have, it's through UW Extension that does have virtual exercise programs, which is nice. So that is an option. I have mentioned it to a few of our participants. And I don't think that you have to even be just in Wisconsin to access it, which is nice as well, but it's through the university. So yes, to answer this question, there's a question in the chat about investigating community-based group exercise that is local, that makes it more accessible. So there are options. And I think Nellie or Ayana mentioned like a YouTube video. We, mentioned, oh, Eleni, thank you. She mentioned or posted the preeclampsia form in the chat as well. But there are, having those conversations to determine what's available for each individual. Wisconsin does have some virtual options. There are people that use YouTube videos that work for them when they're short on time or the ability to get somewhere to exercise. So I think that's a good idea of kind of community-based or just kind of different ways to move your body versus just going to a gym, because that doesn't work for a lot of new moms.
I appreciate that so much, all of your insights. We have about 3 minutes left, and the system will ruthlessly end us at 3 minutes and send us back to the main room. So I guess I'll just give you all any closing thoughts or words that you all want to share with the group, and we can start with you, Ayana.
I'll just say that the National Hypertension Control Initiative, one of its main goals was 80% hypertension control in those 500 awardees. And while we're seeing several awardees reach that goal, which is incredible because all of them started at 60% or less, really the way that we measure success, and we encourage others to as well, is just thinking about improvement overall, that even the smallest of steps, even small numbers of improved hypertension control within patients can make a world of a difference.
Thank you so much. Nellie.
So thank you, Ayana. That's actually one of our client-centered principles. Only a small change is necessary, right? And so we're definitely ascribe to that. And I do want to just talk a little bit or share that it's really important for us to really all collaborate, right? With nurse home visitors, they're in the home working with families, and they're there every other week, right? With the family. And so when a nurse home visitor picks up a phone and says, hey, doc, right, such and such is happening, have it be actually like, yeah, okay, let's work together and figure out what's going on. So it's really, really important for the collaboration to continue to happen, because the nurse, although not at the bedside, not in that clinical setting, is still part of that interdisciplinary team, right, for that particular patient.
I'll just say it's a multidisciplinary affair, and it's going to take a lot of people working together to conquer this. And I think also system changes try to happen, or high up, administrative changes try to make decisions for people, and that might not be right for a particular community. And so I often just say one patient at a time, and that means a lot to me. And so I think if we just keep all trying that, like, we're going to make an impact. And I don't know if Megan, you have any other closing comments?
Just thanks to HHS for, supporting this work and funding it. It's important. It makes a difference. We get to speak to the individuals. And I like Eleni, I've read online, these are your sisters, these are your mothers. So like bringing it back to home, that it matters. Thank you.
Thank you all so much for being here. If you have any follow-up questions, don't hesitate to reach out to us, and we can make any connections that would be necessary. But thank you all so much. We're going to head back into the main room. The next thing is we will have a hands-on CPR demo, which is going to be great. It'll be a little bit change of a pace from just a panel presentation. So we hope that you all can continue to join us. And we will see you back in the main room. It'll close in 30 seconds, or just feel free to click leave room at the bottom right of the screen. See you all shortly.
Produced by the U.S. Department of Health and Human Services.